Hello, my name is Julie Stutzbach. I'm an assistant professor of physical therapy at Regis University here in Denver, Colorado. And thank you so much for listening to this podcast on chronic low back pain in adults with cerebral palsy. Some findings that we have been through with the Cerebral Palsy Research Network about stigma, anxiety, and physical decline. So a little bit about why we are looking into this topic. Adults up to 70% of adults with CP experience chronic pain, which is one of the primary reasons for functional decline. We wanted for our research to look specifically at low back pain since it is the most common location to develop pain in adults with CP. And especially because adults with CP are less likely to access care for their pain than adults without CP. So even though adults with CP have more complications and need care for their pain potentially more than adults without CP, they're actually less likely to seek care for their CP. So we want to have a better understanding of pain and pain interference for low back pain in adults with CP. So we wanted to understand what biopsychosocial factors are associated with pain interference. We had a few hypotheses. One, that greater perceived stigma might be associated with pain interference. Two, that higher functional status, so those with GMFCS levels 1 to 3 would have greater pain interference over those with GMFCS levels 4 and 5 because of a potential floor effect of pain interference with those in lower functional status. And also we thought that people with chronic pain for a longer period of time might develop more resilience to pain. Therefore, people might perceive to have more pain interference if they had pain for less period of time. So we asked how long people had chronic pain and thought that people who had fewer years since the pain onset might have less pain interference. So for our methods, we did a chronic cross-sectional analysis of the CPRN community registry study. This was all self-report. We included 295 adults with CP who identified as having chronic pain of greater than 3 months and low back pain. Some of our results, so on average, we had moderate pain interference levels and pain intensity. Our range was 18 to 78 years. Our average was 42. And we had, people had been dealing with pain for an average of 18 years. So when we say chronic pain, we really mean chronic pain. The range was anywhere from 3 months to 64 years. You can imagine people who said their pain started 64 years ago. Okay, so this is the biopsychosocial model, and that's how we chose to look at this is how we chose to look at the results. And so we found that indeed, in making with our hypothesis, stigma was associated with chronic pain. However, GMFCS level was not, and years since pain onset was not. We also looked at a variety of other factors to strengthen a regression model and to do preliminary hypotheses. And so we found that change in best motor function, employment, satisfaction with social roles and activities, depression, anxiety, were potentially associated with pain interference in bivariate analyses. However, gender, income, age, race, education, and ethnicity were not shown to be associated in bivariate analyses. So we ran an ordinary least squares regression to find the best model to explain pain interference. And of those, we found the stigma to be most important, anxiety to be most important, and change in best motor function since childhood to be the most important. We also did a similar analysis of pain intensity. I'll just report the final model here. And that we found being Hispanic or Latino was a greater risk of having higher pain intensity. Having a higher income was protective against pain intensity. So those with a higher income were less likely to have greater pain interference. Anxiety, again, came out as an important psychosocial factor associated with greater pain intensity. And so satisfaction with social roles and activities more satisfaction was associated with less pain intensity. So what this tells us as far as critical components, specifically of pain interference, one is the stigma associated with disability. So people who perceive more stigma had more pain interference. Now, why is this? The people with CP experience stigma associated with their CP. And if they have chronic pain, they experience the stigma of the chronic pain, and these two things could join together to create more pain interference if they're starting to experience more of that stigma. We also know that stigma can lead to a lack of treatment-seeking behavior, and so those with greater stigma may have been getting less treatment for their pain. Anxiety was also found to be significantly associated with pain interference. This is really critical this is not surprising, but it's critical for clinicians to know that we should be screening for and treating anxiety. Anxiety is a modifiable risk factor. There are treatments out there that can help people of all populations, and this includes people with CP, to manage their anxiety. So we should be screening for that more often and providing appropriate referrals or appropriate treatments. And also, unsurprisingly, functional decline is associated with greater pain interference. So we know that there's a close relationship between pain and functional decline, and certainly the study supports that. So I have some acknowledgements here and some references. There's my contact information. So hang on a moment, because I am going to talk to one of my study participants, one of our study participants in a moment about his experience with getting treatment for his low back pain. He's got some really interesting perspective to share, so please keep listening. I am now introducing Chuck Lacroix. Chuck has been a member of multiple research studies with the Cerebral Palsy Research Network. He's an electrical engineer and has a great perspective on how patients can get better treatment for their CP and what providers can do better. So enjoy listening to Chuck. Low back pain. So thank you so much, Chuck, for being here. Really appreciate your time and your efforts for being a part of the research, and then also for this interview time with the podcast. So if you could just start by telling everybody a little bit about yourself and your experience as a person with chronic pain and cerebral palsy.
Well, first of all, thank you very much. Biographically, I'm 62 years old, electrical engineer for a large company. I think if you had a list of comorbidities or common experiences of people with CP, I probably experienced most, if not all of them. I can certainly relate to much of what's said in many of the forums that I've been in, including the CPRN. I've got it. I was born with it. I'm going to die with it. It's one of those things that you just carry with you. I think for the most part, I was very fortunate, as I had alluded to. I actually am from central Massachusetts, but my parents very early on brought me to Boston Children's Hospital because they weren't satisfied with care in Worcester. And that was life-changing for me. That was absolutely a game changer, because the outlook, the prognosis completely changed. These people were aggressive. They knew what the state of the art was, and they took whatever steps they had to take to ensure that I had the best possible outcome. In that regard, I am extremely lucky and very, very thankful to this day. Like everything else, you get older and functionality is not there anymore. In terms of low back pain, I have suffered a couple of traumatic injuries. For the most part, it's the gait that really makes a mess of your back. I went to see a neurosurgeon at one point, and no less than Mass General Hospital, who told me to leave because I was pretty lucky to be standing up with the amount of damage I did to my back just by the way I ambulate. I thought that was an interesting take on it, but the man was probably right. There's nothing operable. If I went in there, I'd break more than I could fix. So you're not a candidate. And considering what you've done to yourself over the last 6 decades, you're pretty lucky to be standing. I think that's an honest summary from a guy I asked to give it to me straight. He did. So I guess I hope people with CP don't have a lock on lower back pain or anything else. It's just the reason for it might be CP, but I don't think there's anybody that you could point to on the street that's never experienced lower back pain. It's strange to me that people with CP have a higher incidence of back pain, but seek care for it less often. That's contrary to what I would have thought if I hadn't seen the data.
Very much agree. That's an interesting way that the orthopedic surgeon framed your imaging results. But I won't go too far into commentary on that. So maybe I'll just ask, what has really worked for you in terms of helping with your low back pain?
Two things that I know work. Swimming is excellent. I love to swim. I can swim better than I can walk, and that was true when I was 5 years old. It's still true today. In terms of time, I can't get to a lake or a pool or whatever with my schedule. But the thing I've always relied on is physical therapy. Physical therapy, heat and stim. I would recommend having a physical therapist on call if you have cerebral palsy. I have a DPT that I've known for 14 years now, and I just go there for maintenance. I don't even know what I broke, but I broke something. So just look it over, do what you have to do, and thank you very much in advance. And fortunately, with the relationship we have, he can tell how I am before I know. He says strange things like, "You didn't know that you couldn't turn your head?" Well, actually, I was hoping that it would improve, if you must know. So it's just absolutely necessary to build up a support network, because you can't do it alone. I don't know anything about medicine. I just know I can't walk anymore. I better go see Jimmy. He'll fix it. And I don't know how I can express how strongly I feel about physical therapy being necessary. It's not optional. It's absolutely necessary. And I don't care if you have to drag yourself there. Go see a physical therapist. Do the smart thing, wait a week, and if you still can't move, go see a physical therapist. And that's really been a godsend for me. I think it's amazing how much physical therapy has improved or advanced since I was a kid. It's vastly different now than it was back then. And it's amazing what a physical therapist can do in 3 or 4 sessions that you thought you were stuck with this forever. No, just go do the right things and you'll be fine. I've had nothing but positive experiences with physical therapy compared to everything else that's out there.
Mm-hmm. Yeah, and it sounds like you found your PT and you have a really good relationship, and it sounds like that really made a difference for you. What have you tried for your back that has not worked?
Well, I don't know how other people make out with medications. I have never found a medication that wasn't like making a deal with the devil. I don't care if it's spasticity, of course, being the main problem with cerebral palsy. It's the elephant in the room, if you want. It's a challenge to manage it. Helps to play music really, really loud, but that's just me. I found that baclofen was a disaster. All that tone in your legs and your lower back and all that. Turns out you need some of it to be able to walk. You can't be like a bucket of jello. Also, my employer frowned on my passing out at work. I was just taking a nap, no problem. I could never live like that. I took Scalaxin. I was on baclofen for 3 weeks. I'm not doing this. Forget it. I just can't. I have to be 110% full on at work, and it's 50 plus hours a week. I found that any medication you can take just does not do it. It's absolute, go do something better. And I think physical therapy is where I would steer anybody with CP. I think heat and stim are wonderful. And anything that gets rid of tone for a while, if you get to the level that you can't deal with. No, for the most part, don't be stupid, get out of your chair and exercise. That's literally, I have cerebral palsy. The real problem is I'm 60 years old. and I sit at a chair for 10 hours a day. What shape would you expect me to be in other
Microphone. So would you say, so you would say that, so I'm glad to hear that physical therapy was so helpful for you. And it sounds like you've got a lot of really great advice for people with CP. What advice would you give researchers or clinicians who want to help adults with CP with their pain?
Well, I think I don't have any advice to give them. I can tell them the information they need exists. The Cerebral Palsy Network, CPART, information is out there. You just have to find it. Take the effort to go read what's right in front of your face. I mean, I know that Professor Gennady at the University of Hartford is a research, she's been doing this for 25 years, and she's just a resource for physical therapists. She invites people, if you don't know what to do with a patient, call me up and we can talk about it. The resources are out there. That the challenge is to disseminate the information that already exists. And I know a lot of this, probably I'm on the lucky half of the equation from what I've seen and from participating in things. I'm doing pretty well. I'm really thankful for that. But I feel strongly that anything I can do, I will do. But I don't expect anything that a researcher is going to find to benefit me. I'm hoping that it benefits younger patients, pediatric patients. I hope it steers the future for future adults to have a better adulthood. 60 years to figure out you have to manage it. It's, so I would say even for patients that can't advocate for themselves, they need a support network of people who are going to make sure that they have the right care, the right interventions when they need them. And for me, the heavy hitter in the room is keep moving, develop a relationship with a physical therapist. I mean, it's just common sense, yet so many people, when I read the forum on CPRM, I get discouraged. People are out there who clearly need help and either don't seek it or seek it and can't get it. So, I would say even what my DPT told me was, in terms of his knowledge after 17 years of being a DPT, he now owns his own practice. So he's not only a DPT, he's training other physical therapists. He told me, I asked him directly, he said, well, in 17 years, I've had 2 patients with cerebral palsy. The other one is dead, and you're not doing very, very well. So it's pretty bleak. The incidence is so low that it's possible you could go a whole career as a general practitioner. And if you have X number of patients, how many of them are going to have CP? There's no incentive for them to go out and get knowledge. And I say that having had a nurse practitioner who learned all about physical therapy and took care of me for 19 years.
Wow.
To the point that we didn't even speak. She just knew what I had to do, and I had to do it now. So go do this and come back when you're done. She was always right. I learned not to argue. I threw up on her once, and it was just 19 years of care. Like, she retired and I lost my doctor. I essentially lost my doctor. This nurse practitioner took care of me for 2 decades. It's just caring enough to go to a few websites, call a few people, and learn what you have to know about people with CP.
Yeah,
and it shouldn't be rocket science.
It shouldn't be. And it sounds like we as researchers need to do a better job of disseminating our research, especially to clinicians. It's one thing that you're saying. And then, clinicians probably need to do a better job of disseminating their prowess to their patients and developing the kinds of relationships that you have had in your experience with your nurse practitioner and your physical therapist and your specialized care. So is there anything else you wanna say, Chuck, before we close?
No, I think that the paper that you wrote is absolutely 100% spot on. I read it thoroughly, and I've lived most of that, so I know you're not lying when you come out with this paper. It's spot on. The challenge is to see where we can go with it to actually get better patient outcomes. And it's really an underserved population. The incidence is what, 3 in 1,000 or somewhere around there, 2.7 to 2.9, depending on what you read for percentages. It's just an underserved population. And if we could get the right training protocols in place, I mean, educate the educator, so to speak, so that patients don't have to argue and fight. And, you know, as I told you, going to a doctor to see that I needed to go to a doctor, that was helpful. You know, it's just a matter of taking what we already know and using it to improve patient outcomes. And as far as CP patients not seeking care that they need, I don't know how to get past that one.
That's a good question. That's a good question. Okay, well, thank you very much, Chuck. We appreciate it.
Sure, my pleasure.
Okay, so I